Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Doug. How are you doing today?
I'm awesome this chilly morning. Nice to see you, Dennis.
Oh, very good. It is chilly. It's like 34 degrees outside. So what I'd like to talk to you with you this morning is labs and specific lab values and kind of the more practical aspects of it, when to use them, why we're using them, etc. So kind of the first thing I would like to talk about, let's say we have just a trauma patient come in, like it could be a car accident or GSW or a blast, etc. Like when do you even start thinking about drawing labs?
Good question. I think if you remember the podcast we did together where you asked if I was on a desert island and could only have one lab, I think you know the lab I want, which I'll say in a minute. And basically the answer depends on how unstable the patient is. So we're going to assume that this is an unstable, hemodynamically unstable trauma patient, right? Blood pressure is not good, yes. Unresponsive, pretty banged up. That's the patient that I want as much data on as possible because I'm trying to form a picture of how sick they are, right? And so the more information I can have about the more organ systems and the state of their perfusion up front, the better. And so with that said, I would want a pH from a blood gas. So on an iStat, CG, really any of the cartridges will give that to me, but CG8 is the most common, and I think we're probably going to go down that cartridge road a little bit, but a pH as fast as I can get it. And the so what of that is if they are acidotic, profoundly acidotic, so pH of less than 7.2, and often these patients come in at 7.1 or 7 point less than 1 or less than 7 in extreme cases, a bunch of stuff isn't going to work. Their heart isn't going to squeeze as hard as it could. Cardiac contractility or squeeze is negatively affected. And so their cardiac output, which supports their blood pressure, isn't going to work. Their blood vessels aren't going to squeeze as hard as they should to maintain a blood pressure. And in a trauma patient, we're going to start resuscitating them with blood. But in other sick patients, and potentially after blood is going in a trauma patient, or if they are so sick we need to add something else, pressors don't work. Catecholamine vasopressors, so epinephrine, norepinephrine, phenylephrine, their effects are diluted or downgraded in an extremely acidic environment. So I want to know pH right away. And then I want to do something for the patient. I might be anticipating your next question. If I am, I apologize. And then I want to do something based on that pH, and that could be resuscitate. It should be in a trauma patient, resuscitate. So I want to give them some whole blood or whatever blood that I have. And if it's really, really low, like less than 7.15, I probably want to give them some bicarb as well. And then I want to recheck it after I've done my interventions. So, pick a number of units of blood. Let's say I have 2 units of blood available. I'm going to give them 2 units of whole blood. I'd say I have 2 amps of sodium bicarb available. I'm going to give them 2 amps of sodium bicarb, and then I'm going to recheck.
Okay. So, let's say he's starting off at 7, okay, just to have an easy number. We have those 2 units of blood. We're pushing them in. I guess before I get into that, the bicarb question, is there a difference between a venous blood and arterial blood when it comes to your value?
For pH, not really. The biggest difference is going to be your PaO2. And because venous blood is deoxygenated and arterial blood is oxygenated, but the rest of the values are all pretty close between venous and arterial.
Okay. So it's perfectly fine. I already have access to start resuscitating to go ahead and to draw out of that, line. Is there a difference if you happen to be using an IO?
No, not really.
Okay. Just assume it's a venous?
Assume it's a venous, correct.
Okay. All right. Very good. All right. So we got our values. pH is 7. We're going to go start pushing the blood, obviously, first. And like at what time, like what kind of response do you want to see? Or if it's from those units of blood to tell you I'm going to give bicarb, or do you just do it?
I would just do it at a pH of 7. At a pH of 7.2, I wouldn't do it. At pH of 7.25, I wouldn't do it. At any pH of less than 7.2, I'd probably do it because I want as much metabolic assistance supporting blood pressure as I possibly can get. And the other thing that comes on the cartridge that I'd be looking at as well would be an ionized calcium. And if that's low, I'm going to give my calcium up front and not wait for the blood to go in and give it to offset the effects of citrate calcium binding. So that would help me make a decision of, is my calcium going in after 4 units of blood as usual, or is it going in like right off the bat? So.
And that also just kind of points that you're going to need multiple points of access because we're going to start pushing a bunch of stuff fairly rapidly. Yeah. So you have one line, you got your blood coming in, at least one more that you can start pushing your medications. Right.
I mean, you can't be a patient in our ICU without 2 working IVs or an IV in the central line, but you have to have 2 points of access, 100%.
Okay. So let's say we've done our 2 units of blood. We've sent our 2 units of bicarb. How long do you want to wait to start getting like repeated values so we can, can you even say it's a real trend? Because we've already intervened justifiably at 7 of pH, but like we've kind of already intervened.
Oh yeah. Trends aren't just like natural history if you do nothing. Trends are, trends can be positive as well, right? And so, if you remember ATLS, there are 3 types of shock courses, right? They're responders, they're non-responders, and they're transient responders. And you've already diagnosed that your patient's in shock, right? They're profoundly acidotic, they're hypotensive, your mechanism is hypovolemia from, hemorrhage, most likely from blood loss. And so now, you don't need to wait for them to declare that they're like profoundly sick and they're getting worse because their next step might be cardiac arrest. You need to, now start, your positive trending, you're trending to interventions and say, hey, did they respond? If they did, great. And then B, have they durably responded? Or, are they going to slide back again? In which case they're a transient responder and it's time to do more resuscitation. Or did they not respond at all? A bit more on the rare side up front, especially with a trauma patient, but I guess it happens. If they didn't respond at all, then, try something else, but then really start asking, am I missing something? And so one of the common things in trauma that you could miss as a other alternate mechanism of shock would be obstructive shock. They have a tension pneumothorax or they have a hemothorax and cardiac tamponade. And that's actually happened to patients of mine in the hospital, cardiac surgery patients or cardiac intervention patients, where we thought they were in cardiogenic shock. We're doing all the right things for that, and they're not responding. And we throw an ultrasound probe on them, and the small pericardial effusion has now become large and it's compressing, cardiac chambers. So non-responding to shock, and I know this is a talk more about labs, but you use labs to make clinical decisions, and so is part of non-responding to interventions should trigger you to think about, am I missing a mechanism? Am I missing something?
Yeah, absolutely. I guess especially with adding bicarb to it, how much of a response do you expect to see?
I would expect to see the next pH. Unless they're actively exsanguinating, which I hope they're not. I hope you've either got compression of compressible hemorrhage and that they don't have like a major interior arterial bleed, which would be catastrophic. But let's say absent those two things, I'd expect to see the next pH above 7.2. We have these patients come in cardiogenic shock mostly, but we have some hemorrhagic shock as well, postoperative bleeding, post-procedural bleeding, and their pHs are in the sevens, low sevens, 7, and we can get them up in the 7.3s with just one round of bicarb. So
okay. How long would you expect the bicarb to last?
A good question, because it's not just the bicarb, it's their own metabolism's response to the resuscitation. So, you almost never give bicarb in a vacuum. You're always doing it as part of something else. You're giving blood to resuscitate hemorrhagic shock. You are putting them on an inotrope to help the heart squeeze harder in cardiogenic shock. That inotrope, epinephrine for us as first line, is not going to work very well when the pH is 7, but if you get it over 7.2, it's going to start working. So it's really hard to characterize how long that bicarb is going to stick around. I would, and a lot of that really depends on, because it's really part of a composite picture of how sick your patient is physiologically. And if they are a responder or a non-responder. So hard to say.
So obviously we beat, I think, pH to death. Now there's a bunch of other aspects, like you mentioned, ionized calcium. We have with the CG8 test, you have your ionized calcium, you have your H&H. You have all your blood gases. Are there any real value in getting those?
The biggest, I think, asset of the additional labs would be to help you manage your ventilator with the blood gases, right? H&H, I'll get some flack for this, but I honestly don't really care about an H&H. In a bleeding patient, I don't need a hemoglobin to tell me they're bleeding. I need an ultrasound to tell me they're bleeding, or I need open wounds to show me, is it a venous bleed or an arterial bleed? And if it's an interior bleed, I need an ultrasound to diagnose it, and then I need serial ultrasound exams to tell me, is it getting bigger? I think it's one of the biggest misconceptions in trauma and hemorrhagic shock resuscitation. I think the trauma community is really good about this because they understand that hemoglobin is something that equilibrates with volume shifts, but they're about the only community that does. Everybody else is like, the hemoglobin's fine, they can't be bleeding. And, you've got 2 chest tube atriums full of blood, like 2 liters of blood in the chest tube atriums. And I'm like, sorry. So I wouldn't worry about that.
So just monitoring blood pressure, our normal
ultrasound,
hemodynamic monitoring, ultrasound, if you have a urine output starting anyway.
The only time I've seen hemoglobin be useful as a diagnostic tool is somebody has like an occult bleed, right? They have a GI bleed and, they've had bloody bowel movements for, weeks, or they have like a retroperitoneal bleed from either blunt force trauma that they ignored. They had a car accident and their hips hurt, and then their hips hurt more. And now that, but they never got it checked out. And all of a sudden they've got like 2 liters of blood in their retroperineum in their hip, and they come in and their hemoglobin is 4. That focuses the mind. But as far as like, as a dynamic ongoing trend in a trauma resuscitation or hemorrhagic shock resuscitation, it's a lagging indicator. So I don't follow it. Now, the blood gas, super useful for managing your vent, right? Your PCO2 can be helpful. Now, if it's a venous blood gas, your PaO2 is not helpful. It has to be arterial to give you meaningful oxygenation levels. But a pulse ox is very reliable as well. So a PCO2 is much more reliable than an end-tidal CO2. In my experience, is that it's much easier in theory than in fact to get end-tidal CO2s that are close to PCO2 blood gas values, and they could be off by as many as 20 points. So, what do you do if, you've got an end-tidal CO2 and a SpO2, and your SpO2 is 90 and your end-tidal CO2 is 20? But it does not look like your patient's hyperventilating. You're not giving them, 20 liters a minute of minute ventilation. What do you do with that 20? You probably chalk it up to measurement error. And if you were to check a PCO2, it's probably in the mid to high 30s. So it's a good check on your. But the other thing too is it is a good check on your end-tidal CO2. So if you got you have this patient that is unresponsive and needs to be on a ventilator, maybe is hypoxic as well. Your SpO2 is usually pretty reliable means of tuning your ventilator. So you don't need to like brush up on your skills of sticking an artery for blood gas. That's tough, and a hypoperfused artery is even harder to get than an artery into somebody who's like perfused is hard enough to get. A radial artery, somebody who's hypoperfused, it's going to look like the tip of a pencil. So on an ultrasound, so good luck. Even for me, we have trouble. A lot of times we have to put them in bigger arteries like the femoral or the axillary, and that's fraught with a lot of risk. So good thing that the pulse ox is reliable. And then you can get a PCO2 and basically quality control your end-tidal. Right? If your PCO2 is 40 and your EMA is 38, then your EMA is pretty close, and you can just go off of that and not have to burn any more cartridges to tuning the ventilation mode and tuning the carbon dioxide mode on your ventilator. Make sense?
Right. Oh yeah, it absolutely does. Now, some of the machines, like your iStats, like they do some kind of math and algorithm and convert venous blood numbers and give you a representation of what they would be arterial. Like, is that reliable?
I don't know. I've never used it because anytime I'm getting an iStat for oxygenation, it's always arterial. So I don't know. I would say try it, trouble check it, quality control your SpO2, your pulse ox, but when in doubt, go with your SpO2. Because you always want to get your data from the most primary source possible, the most direct measurement possible. So it's one of the reasons actually that, we get bicarbonate on an ABG, but bicarbonate on an ABG, bicarbonate, in your blood, is not a directly measured value on the iStat. It's calculated. And, they'll have people come and say, oh, the bicarb is low. And I was like, well, did you get it on a blood gas or did you get it on a serum? I was like, oh, we got it on a blood gas because we were, adjusting the ventilator or adjusting the ECMO circuit. And I was like, and then you got it on the calculated one, or on the directly measured one on a serum chemistry, and it's like 5 points higher or whatever. So, which is significant, right? It's like 25%. So I have a healthy skepticism about calculated values on any lab to include iStats.
Right. It's probably, I would imagine the calculation is going to be based on healthy people versus trauma people. So, right. So it's an estimate, just like most other things in medicine. We get our data off healthy people and try and extrapolate that to unhealthy people. Yeah. And it's going to be off, right?
And then the only other... go ahead.
I was going to say, so like we're talking about different values to get, which has been great, but like how frequently are you drawing these? Are you doing it every 10 minutes, 30 minutes, an hour? Because that's a lot of labs. That's a lot of cartridges.
Correct. I don't think we draw labs as frequently as every once in a while. Maybe we'll draw something every hour. But we don't use labs that frequently. We use labs, and labs should be used to help establish an initial diagnosis of mechanism and severity, right? Because they add, like I said, they add data, right? If you've got somebody who's, mean arterial pressure is 40 and their pH is 7.4, that's a totally different pH. They're compensated. If you have somebody whose pH or whose, mean arterial pressure is 40 and their pH is 6.9, they're decompensated, totally different patient, much more unstable. So that's your initial snapshot. And then if you are doing interventions that, can affect those initially bad looking labs, and getting another set to reassess the effect of your interventions, would be reassuring. Then get a set after you do your interventions. And then after that, it really depends, because especially in a tactical environment, a resource limited environment, I would look for what else is altered when this patient looks bad and is looking better when this patient responds, and track those trends rather than keep sticking them for labs and burning cartridges, right? So, yeah.
Yeah. I mean, that makes complete sense. Like, I'm doing a lab because I want a number, and I want the number ideally to be within this range. But if it's outside of this range, maybe I make an adjustment. Right. Well, how much did that adjustment affect?
Right.
Well, now there's another lab. But you don't just do labs for the sake of doing labs. It's not part of the vital signs that you're gathering.
Correct. And labs take time, right? In the hospital, labs go to the lab, and they have to get drawn, they have to get packaged, they have to get labeled, label has to get printed, they have to get labeled, they have to get sent to the lab or carried to the lab has to process them, and they have to post the results. And so labs, even in the hospital, are not instantaneous. Now an iStat is quicker than the lab. The iStat still takes a few minutes, it still takes a few minutes, and lots can happen with the vital signs in a few minutes. So, we're getting labs if we see a trend that we don't like and we want to double check something. So let's say, patients been stable, blood pressure starts going down, we're going up on their drips. We ultrasound them in their inferior vena cava, looks like it's collapsing where before it was more resuscitated. Heart looks more hyperdynamic when before, it looked like the preload was better. And we're going to make a decision about, well, do they need a depressor, an inotrope, or more resuscitation? Then we would actually probably do that intervention And then if things didn't get better, then we're like, well, maybe are they so acidotic that, the bicarb's worn off, or, the metabolite, they're not responding to resuscitation as well as they had. Let's check a pH and see if, let's check a pH. So, but it's not a reflex, right? Like, trending labs for us is like every 4 to 6 hours.
All right. That makes sense.
And that's more for like metabolic things like potassium when we're diuresing somebody.
Right. Right. So for a trauma, more than likely, once you get out of this dangerous zone, right, you get a patient at least more stable, if not hopefully stable. Now we're just essentially leaning on our normal vital signs that we'd be getting, heart rate, respiratory rate, blood pressure, cap refill, something like that. And then if there is a change from that trend, potentially, that can be solved with another lab.
Yeah, exactly.
Okay. Then you make your intervention, recheck your lab, especially if I would imagine, especially if you're making a change based on a lab value. Once you do the intervention, then recheck it with the lab value, because you didn't pick it up with all your other monitoring gear.
Right. And, a special case that we haven't talked about yet, but I'm sure we're going to get to, is something where the lab value is one of the most concerning things about your patient. And so, in that situation would be crush, right? Crush and compartment syndrome. So, there, potassium is the life threat, right? High levels of potassium is the life-threatening injury. It could also be along with trauma and internal bleeding, but even in a patient that didn't have significant levels of internal bleeding, high potassium could kill them from, causing an unstable cardiac arrhythmia. And so there you would, if you have the capability, trend your labs. You would, get one to begin with. You would put them on the fluid. You would make sure that their urine output is, you would do everything you can to ensure the brisk urine output that you're supposed to get, or you're supposed to aim for. But then you would trend them at least, I would, if you had the capability, I'd trend them until I handed them off to a higher level of care. And trending probably means every 4 hours.
That's exactly what I was thinking. Yeah. Okay. And just from that, obviously you're not just watching the numbers, right? Like you already began intervening with, like you mentioned, with the fluids, getting your urine output up. You have your calcium standing by in case any weirdness happens. And then essentially just watching, right? I guess especially when it comes to crush, at what point, if we're just watching lab values, I really don't have a 3 lead that I can monitor. I'm watching the patient. I don't really see much of anything. At what point on these serial labs are you going to say, what, screw it, just send the calcium?
Oh, you mean check a calcium or give calcium?
I'm watching the potassium. It's slowly rising, but I'm not like visibly seeing anything from the patient. Their heart rates are high. It could be, is it because he's in pain? Is it because he got incredibly surprised by this giant weight that crushed his legs and his life is now completely changed? Is that why his heart rate is high? But I'm noticing, every these 4 hours, it's just coming up a little bit more. At what point do you just say, screw it, just send the calcium because I want, an overabundance of caution? Right.
But I think any potassium greater than 6, you should be giving some calcium, because calcium is relatively, it is benign. You could think about it over 5.5. We have hyperkalemia, high potassium protocols in the hospital, and you plug your patient's calcium in some other values, and it'll advise you whether you need to do anything or not. And generally below, I think it's below 6.0, they're like, yeah, just watch it, don't do anything. But because you're limited in the field, you probably don't have insulin and dextrose, you probably don't have nebulized albuterol, you probably don't have a potassium binder, then I would err on the side of caution. And once it creeps up over 5.5, give the calcium early. You're not going to hurt the patient, and because basically all you have for crush in the field is calcium and fluid. So if they're not responding, if you're giving fluid, if you're getting the right urine output, your potassium's still creeping up, I'd give the calcium early, because you don't have some of these other tools that we do in the hospital.
Okay. Another thing about crush. So let's say I'm noticing my potassium is slowly creeping up, but my urine output is, 250, 300 cc's an hour. My intervention doesn't seem to be keeping up with the problem. Is it okay to just raise it?
Sure.
To just raise my urine output? Okay. All right. Perfect.
This is where, sometimes I think about advocating for the use of, or the fielding of Lasix, furosemide, in crush kits, because it's an easy to administer drug. It'll help your urine output, right? So that hydrostatic flow that's keeping the, not only eliminating toxins through kidney clearance, but increasing the hydrostatic flow rate that's keeping myoglobin from getting stuck in the tubules, and it lowers potassium. So we put people on diuretics for heart failure and cardiac issues all the time, and one of the things we have to be really careful about is that we don't diurese out so much potassium that we drop their potassium to life-threateningly low levels. So, 40 milligrams IV of Lasix, I think, would be a fine addition to anybody's crush kit.
Right. No, I think maybe it's something we're not necessarily good at. Like, it's okay to give a small amount of a drug and see what starts to happen. Just like calcium, it's okay to not just slam it into the vasculature and see what happens. You can put it in a bag and just let it drip in, and just no drastic effects. That's definitely something I don't really want, is rapid effects. And
that's a low to moderate dose of Lasix. And somebody who's Lasix naive, right? So somebody who's not on heart failure or on home Lasix, like you or me, if you were to give us 40 Lasix, I mean, we're gonna pee pretty briskly for several hours, potentially 12 hours. And in a condition like crush, that's beneficial. So
if you have the fluid to back it up,
tailoring your drug intervention to the situation, and being cautious to moderate with your dosing, I think is fine.
Are there any other values or labs that you're really chasing? I won't say you're actively chasing if you're talking once every 4 hours, but other values. Okay, we talked about your pH. We talked about your gases, your CO2, your SpO2. Talked about bicarb, potassium. Are there any other values that are important to watch and trend and potentially intervene on?
One other special situation, head injury. If you've got a patient with head injury and you're giving them hypertonic saline, I would watch the sodium occasionally. Probably get a baseline value when you do your first dose, and then sodium generally in hypertonic saline takes a long time to rise, like a day, over the course. It'll take over the course of a day to get to something that's not good. but it could be faster. So, again, I would do baseline intervention, give the hypertonic saline, follow up. And that'll equilibrate pretty quick. So, give it, check a sodium 30 minutes after you give whatever bolus of hypertonic saline you have, or whenever the drip, if you run it as a drip, whenever the drip runs out. And then you probably want to not be giving hypertonic saline with a sodium level above 150.
Okay. All right. Very good. One thing when we're doing like our head injury type lanes, I've noticed maybe more in the past than currently, but there's a fair amount of hesitancy when it comes to like pushing that hypertonic, and they're waiting for like blatantly obvious signs that this patient they're herniating, what would happen if you were to give a one dose your 3% saline to a perfectly healthy person who did not have a head injury? What would happen to them if they got a dose of the hypertonic?
Nothing clinically significant, and you would really have to hunt for a response in the labs. You would have a very effective volume expander by isotonic forces, not osmotic forces. I'm sorry, oncotic forces, not osmotic forces. You would have, your kidneys could keep up with that to the point that your serum sodium would be unaffected at all. And if it was, it would go up by 2 or 3 points with 250. So basically you would have to really look under some rocks to find any changes, and clinically, physiologically, it would be completely insignificant.
Yeah. He would be really thirsty.
Not even. Right. You'd probably be less thirsty.
Not even.
Because you got a nice volume expansion. You're more, your volume is even better. So the hypertonic saline makes a great resuscitation fluid. It's the volume expanding. It has the volume expanding characteristics of albumin, without the glass bottle storage, and it does double duty. It works great in head injuries as well.
Okay. Especially, if you're just looking for volume expansion, right? We're not there's a reason we don't pick it for trauma.
There's a reason we don't pick it for trauma, because, salt water is for pasta and blood is for hemorrhage. But yeah, the earlier the better in head injury, I would say. If they're herniating, it might be too late. I certainly would at least give it at the first sign of pupil irregularity, sluggishness, not reactive, starting to dilate. I would not wait until, they became bradycardic with a wide pulse pressure, that's too late.
Yeah. Kussmaul's respirations, exactly. Anything like that. Yeah. Yeah. It's there, at least in just the couple of patients I've had with those types of signs and symptoms, it's incredibly hard to get them to turn around.
Yeah. No, it's almost, unless you've got a neurosurgeon standing by to do an emergency craniotomy, it's almost impossible. And I've been in situations where you have, and when you have and they've responded, and you haven't, and you have and they haven't responded. So, yeah, earlier the better. Be super attentive to the pupils.
Is there any other values so essentially we've been talking about the CG8. The only benefit, if it is a benefit of CG4, is that it has a lactate. Does lactate tell us anything that we won't get with our other monitoring gear? No,
lactate won't tell you anything that you don't get with pH, right? And if you have an elevated lactate and a relatively normal, greater than 7.25 pH, then, there's no need to intervene for the lactate, in my opinion.
Like we're not, yeah, it's not, it's supposed to be, at least from what I understand, and there's, I'm sure, a lot about lactate that I don't understand. It's supposed to be like the canary in the coal mine alerting you that something is wrong. Mm-hmm. But if you have any kind of sensitivity to any of the other monitoring gear, I would imagine you would know these things probably faster than you can do the labs.
Correct. And that's exactly right. It can be a canary in a coal mine. I mean, you can have an elevated lactate and then your pH goes south later. You can also have an elevated lactate and your pH stays normal, and you can have a rising lactate, that says you need to do more resuscitation, but you have other stuff then, the blood pressure, you've got heart rate, etc. So I don't know. I don't follow the lactate nearly. Now I'm probably in the minority. I don't follow the lactate nearly as, I'm not as concerned about it nearly as much as a lot of physicians. So take that with, this is my opinion, grain of salt.
Yeah, no, of course. Of course. I think maybe in the future I need to do just a podcast on lactate, because
should probably do a pro-con, like when Evan and I did the trach versus endotracheal tube, and you get one person who's pro-lactate and another person who's, sort of doesn't follow it as much. I'd be happy to volunteer for that second spot. And then have a discussion, because, a lot of times one of the beauties of that podcast I still get comments about was how we each sort of influenced each other's thinking over the course of a podcast, which is kind of cool to see.
Yeah. I mean, that should be any discussion, right?
So I think, for labs, you can so get into the weeds with labs, right? And people at all levels of medical training get into the weeds with labs, and they get fixated down and in on the labs and not looking at the bigger picture of what does the patient look like? What do their vitals look like? And so what I've hoped to provide was some context of, what labs are really important, what they can add to your assessment and management and reassessment of the patient, and, what is a reasonable expenditure of your scarce lab resources in the field. That was kind of my goal.
Yeah, no, it absolutely was mine, is because I think anytime I've heard a discussion about labs, they're talking about a value and how closely it's tied to whatever and whatever, and how it's super important. Nobody ever tells you is like, well, when do I do this? Like in the spectrum of, what we're going to be doing with the patient, when do I now have time to do this, and how frequently am I measuring it? Right.
Cool.
Well, awesome. Thank you, Doug. I really appreciate you jumping on.
Hey, great to chat with you, and I hope you had a happy Thanksgiving, and everybody else in the audience did, and we'll see you next time.
See you next time. Thank you. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.